kind of have some open dialogue tonight about these more Prophy codes. It's kind of what Kathy and Carol and I talked about last week. So thank you guys for joining us. I'm Tasha, and I'm down in Houston, Texas, but right now I think I'm in College Station somewhere. So I'll pass it over to Kathy to introduce herself.
I'm Kathy Forbes. I'm just south of Denver, Colorado. I am the mentor from the DCC. I have quite a bit of experience with codes and writing them and speaking at the CMC, and I attend those meetings. And so I'm just here to kind of support Tasha as we go through this group. So welcome. Okay. Eileen, you want to go next?
I don't mind. Hi, I'm Eileen Prizzi. I'm from New Jersey. I talk fast. Sometimes I think I can't keep up with my thoughts, so I trip on my speech. Very, very passionate about what's going on here. I think this is a really cool time. I'm in general practice, and the oral systemic, it goes back to, treating people that are medically compromised, and also, seeing what as hygienists we can really do to help them manage their illnesses, and also periodontal disease. If I hear, I've been a hygienist 40 years, and if I hear one more time, it's just a cleaning, it makes me absolutely batty, because we are so much more, and we can impact the health of the people in this nation. And we have to kind of get through some of these barriers, because they're really, really stifling what we can do.
Absolutely.
I'll go.
Susie, you want to go next? Oh, Carolyn?
Oh. Carolyn, go ahead. I'll go in after you.
All right. I'm Carolyn Zeitz. I live just north of Detroit, Michigan. I'm a full-time faculty member at University of Detroit Mercy Dental School. And I'm a hygienist, and I work primarily in pediatrics. So I like this idea of changing the codes to actually reflect what we're actually doing, and sounds like a good group of women to be working with.
Okay, I'm Sue Brzezinski, and I live just outside Buffalo, New York, in the suburb of Tonawanda, near Niagara Falls, New York. I work in a general practice, and I've been a hygienist for almost 50 years.
Woo!
Nice.
Yep, I try.
Awesome. And Joy, what about you?
Hi, I am Dr. Joy Voigt-Holmes. I am a dental hygienist with a doctorate degree. I'm a part-time educator at Fortis College in Landover, Maryland. That's about it. Been in dentistry since 95.
Woo.
Awesome. Very good.
Congratulations on your
Great.
doctorate.
Thank you
That
very
is
much.
so cool. That's so
Thank
cool.
you.
Yes.
And I might add, I'm
Awesome.
a part-time faculty member here in Colorado with over 25 years teaching, mostly in Washington State. I've only been in Colorado for 5 years. So I'm with you, Eileen, that every time my students say to a patient, yeah, they wanted your cleaning, I just cringe.
Yeah, and I forgot to mention too, I'm an adjunct clinical faculty at Bergen Community College in Northern New Jersey. So I'm going into my 3rd year, and they didn't even talk about oral systemic. And it was interesting because June was Alzheimer's Awareness Month, and I went into the locker room summer session and I said, okay, so June is Alzheimer's Awareness Month, and all of you students are going to talk to your patients about P. gingivalis, right? Crickets, So we are starting to introduce and really talk more about the oral systemic link in school.
Yep.
So.
Absolutely. Well, thank you all for introducing yourselves.
Yes.
Thank you.
So, Miss Kathy, if you wouldn't mind pulling up the PowerPoint, we can touch base on a couple things that we discussed last week.
Let me see. Is it showing up?
Yes. Yep. Thank you. So just to kind of recap, I'm not sure if everyone had the opportunity to, review the recording from last week's call. There's a few people on here first I would like to mention that can't make, Is that okay? Can you hear me?
Mm-hmm.
I think so. Okay. There's a few people on here that have some family things, or they're not able to make the call. So, but they did send some feedback. So I put some things here in the slides for us. So mainly I just wanted to catch everyone up on what we talked about last week. So on the next slide, Kathy, so basically last year we submitted, I believe, 6 codes. So it kind of goes back to what Eileen was mentioning. So let them keep their Prophy, but maybe change a few things up, submit a few extra codes. And they really pushed back, saying it was more disruptive to a commonly known code, and they really weren't having it. So what we talked about last week, and Kathy can kind of scroll through these rejections, but if you'll see the rationale, it's kind of consistent, that it says it's disruptive as it blends two well understood established CDT codes, and some of them just say it's disruptive because it messes with basically a well-known code. So a lot of feedback about it being disruptive and not really wanting to change what was there. So our thoughts last week when we discussed, and we have a lot more people on today so we can discuss further, was rather than submitting these 6 codes again and trying to change so that it would fit the diagnosis that we're actually doing, was to submit less codes and maybe just broaden the definition. So just to elaborate more, we feel like there's still a gap between the 1110 and the 4346. So we were trying to kind of broaden the definition to where we're just tweaking a few things and it's not so disruptive, but we kind of get everything encompassing what we're trying to do here. So some of Eileen's feedback is on the screen, and I know you can't really see her in here, but she's on the line and maybe she can pitch in a little bit. But some of the feedback's on the screen here, like she said, tired of hearing it's just a cleaning. And for the purpose of metrics and coding, we know that a ton of people are falling into the 1110 bucket that really probably need something more. So we wanted to kind of broaden the definition to where we didn't have as much gap in coding. So I'll stop there and just see if anyone had any questions from the recording from last week, or if there's any confusion at this point right now.
Tasha, if you want me to jump in, this is Eileen. I know you can't see me,
Sure.
sorry. I'm not that advanced
That's
yet
okay.
technologically, but you can call me Nick. But their own language is what gives us the ammunition, I believe, because their own language, what is routine? That's not defined. What is normal or good? In a court of law, this stuff is just it's way too loose. So pockets are absent. Well, in a normal healthy focus, it could be 1 to 3. So it just takes this and it goes through and it tells everybody, happy, you're fine, you have no issues. And so when the majority of malpractice cases come through and they are awarded, it's for not identifying and treating periodontal disease. And going to the future, it's not just going to be about losing teeth. It's going to be, you could have helped this patient. The lawyers are always looking for new things. You could have helped this patient maintain their inflammation, and now they have Alzheimer's, or now they have this, or now they have that. I'm not saying that's happening tomorrow, but there's potential for that down the road. These codes also, if I'm not wrong, this 1110 goes back to 1995. There was no such thing as oral systemic link. There was no classifications. So just by even our patients seeing and reading and hearing all this stuff in the news, every single week there's something. I mean, it's a different time, and their responses just aren't germane anymore. They just don't make sense.
And I think from a standpoint when we do, I'm trying to get, there we go. If I might interject, that these kinds of things that you've brought forward, Eileen, will definitely fit into when we have to write the rationale for this. Because the document that we could change request form is 4 pages long. And so, we can have what the code is, but there's a whole section on rationale and a clinical scenario and other things. So you've brought up some really good points that we'll be able to feed, and we'll probably have you help write that section in the change.
The rationale.
Yeah.
I'll be happy to.
So
I agree. I think I saw a lot of, I know you can't see Nick or Eileen, but I know you can't see, but there's a lot of shaking heads. Everyone's shaking their head like we all agree. So yeah, we definitely agree that we're in a different time and our coding needs to really better align. So if you'll go to the next slide, I just wanted to share some of Susie's feedback. The concern was opening up the 1110 in the definition, as with other codes, is if the CMC would reject us thinking it was more of a laundry list. So Susie, I know you're on. Did you want to share kind of a little bit more on that?
No, it just seemed that if you're saying, okay, you know, if a patient has this and this and this and this, you're making a laundry list of things.
Yeah.
If there was some way we could, I'm Italian, my hands are going. You know, if there's some way we could consolidate it, that it would sound more professional. I don't know, but it just seemed to me that everything was a laundry list. And didn't they reject us on that?
that's
way back
part
in
of
the
it.
beginning?
Yes, Susie, that was
Yeah.
part of it, is that we were breaking it down into what we would understand, but they couldn't understand how you could have 6 codes. And so we had to laundry list, this one is this, and we had a flow chart for them to help guide them, and it still didn't, you know, pass. So you're right, that's one of the reasons we thought we'd pull back and do kind of a less is more kind of approach.
Right.
Now,
So if we'll, oh, go ahead.
I was trying to do my own little research before tonight, and when I went on the ADA website, it gave the purpose of the CDT code. And what's interesting is that, you know, they don't like the laundry list, but yet in their own verbiage, it says the purpose of the code is to achieve uniformity, consistency, and specificity in
Yep.
accurately
Mhm.
documenting dental treatment, but yet they don't want us to do that. So how are you supposed to use a generic code and then also try to fit a Snowdent code or the other codes that are going to be coming down the pipeline for diagnosis?
And that
I think,
Right.
yeah, that's a challenge. But you know what? We have to start thinking like lawyers. We have to start presenting like a lawyer, as opposed to a clinical hygienist or an educator, because that's kind of what they understand. And if they have an understanding that they can be liable if they're not, you know, more diligent about this code going forward and about the services that's provided in their offices. And you know what? If it's out there every day and they want to toe the line, the dental community, they don't want to get on board with the medical community. Either they can do it now of their own free will and volition and go forward and say, hey, you know what? The time is now. We see it. We're on board. Or they have the possibility of being, you know, shamed into it later, or even miss the boat and be embarrassed. So I think that if we just kind of present it to them somehow with some good language and more of a legal, you know, format going forward, it's not just, you know, a bunch of cleaning ladies coming together that want more codes.
no,
And I'm sorry to say it that way, but, you know.
no,
Mike?
if I can just interject something here, it brings to mind when we're at the CMC, if we could have some attorneys, even at least one, that is that defends patients, that could bring this up, it would get there. I hate to say, if we had a male attorney, I hate that. When you go to this meeting, you would be, we've got to play the politics a little bit. But if we,
you have to play the politics, but you also have to bring it, and you have to bring fact and truth and science,
right.
and just stand there and like, you're going to tell me this. And if we had an attorney present something, if we had somebody who, you know, even if we could get in touch with a malpractice insurer, you know, to say what you're getting sued for and what's this or that, you know, you're coming with a different spin. You have to bring bigger, smarter guns.
It would definitely get their attention.
Yes, ma'am.
But the thing of it is this, are they going to come back at us and say, you know, you're not allowed to diagnose? Or
no, Susie, they don't even go there. They really don't.
They didn't even say that once in any one of their responses. They were just doing the bully thing.
No, they were more talking about that we were getting into diagnostic codes. They didn't say who determined it. but
No, right, it's a smoke screen.
yeah. So
All right, well, what if we
the
use
idea
it
of
for medical?
the idea of
medical or dental?
diagnosis by a hygienist has been a non-issue. It's never come up in all the times I've been there. So.
All right, well, how about instead of a laundry list, use like the word medical and dental conditions or something?
Well, how about if we take a look? Tasha has some slides that we've got some suggestions. So how about if we move to that? Okay. Of course, this is the one, this was the first one we brought up. Tasha, you want to?
Sure. So the black font is as it's currently presented. So the 1120 removal of plaque calculus and stains from the tooth structure in the primary and transitional dentition, and then it is intended to control local factors. Basically, is the current definition. Our thought, because last year we tried to submit something for the reduced periodontium patient, and we also tried to submit something for the primary transitional and permanent. So our thought was to add in the phrase, which is kind of stemming from the 4346, where there is gingival health, to localize gingival inflammation in the absence of periodontitis. And that way we could kind of open that up for the gap between the 1110 or 1120 in the 4346, because today if someone has generalized slight gingivitis, there's no code for them, right? Or at least it feels like there's a gap in coding there. What do you do with that patient? So it doesn't necessarily tie in. Oh, go ahead.
I'm sorry, the biggest thing that jumped out at me on that 1110 with all the gingival health and all that, it says coronal. You and I all day long, we're not just working on the coronal.
Eileen, that's the old model. That's not the current definition. That was an old definition.
All right.
From 1990. Yeah, that was one of the original definitions. They eliminated that a while back. So this is the more current.
So can we do something with regard more to bleeding sites? Does that make sense?
So currently the 4346 would be a patient with that generalized moderate to severe, and a lot of that gauge might come from that greater than 30% bleeding or greater than 30% inflammation. So our thought was to capture the patients who are falling into this kind of foreign area, there's no code for them, was to add, so in the 1110 today, removal of plaque calculus and stains from the tooth structures in the permanent and transitional dentition, adding where there is gingival health or less than 30% of the dentition exhibiting gingival inflammation. So you can strike the word localized, but today it's kind of just, it's very vague. And so we want to try to close the gap there for those patients. Because otherwise we're using a code, we're still having a patient with inflammation, but the metric, so to say, says that they're healthy.
So we're using their measurement from what's his name in Sweden with the 30%, which is what their rationale tends to come up with. So we did less than 30% for the prophylaxis, and then if you drop down to the 4346, it's 30% or more exhibiting generalized gingival inflammation. We didn't want to limit it to moderate to severe. And really, Teresa brought up a fact that if you take that out, it could be, most of our patients will be a 4346. And I go, yes, they are.
Yeah, and they are.
Exactly.
If I can jump in, and when I introduced this into my office, we started using it because when I would see people that hadn't come in a long time, but for insurance to consider it, first of all, my office wanted to charge a higher fee for it. For the insurance company to consider it, they needed the comprehensive exam from the dentist first. Then when you did that and you submitted it, they said no, and they kicked it back to a 1110 code, and that's what they paid.
Yeah, they can recap it. Yeah.
Right, and so then the office manager is saying, well, I'm not going to send it in as this because they're just going to kick it back to a 1110. So that's where the whole thing comes in, where you want the coding, you want to see who has periodontal issues. You want it to somehow come into medical necessity, because it behooves the office manager to submit it the right way, no matter based on what we see going on. So there's a couple things. We're dancing with a lot of different factors. The person who's submitting the claim and what they're going to see. If they send back to 43, 46, and the insurance company is going to knock it down or cut it back, well, why didn't you bill for this other one? So you're going to have to explain it to the patients that you're not trying to rip them off. And the dental malpractice side, and then the insurance company. So we have a lot in our audience that have different reasons why they would want something or not want something. So we kind of have to anticipate where we're going to get the pushback.
Well, one of the things that we've tried in the whole consortium is to, as we create codes, yes, we're mindful of what insurance carriers do, but we can't be concerned with it. We need to come up with a diagnosis and pick the procedures. And
agreed.
One of the things that happens, and I've been around dentistry 40 years watching this stuff happen, is that when a new code comes in, it takes about 3 to 5 years before the insurance carriers really decide we're going to benefit. So we're right in those, honeymoon years with 43, 46, and if we don't keep submitting it, they're allowed to remap it. They'll have to.
I was just gonna say,
If you don't lose it, if you don't use it, you lose it.
Exactly.
So that happened when we started to submit for composite. I started front desk.
Yes.
So when composites came out, they would always kick it back to an amalgam, and eventually they started paying the same or just paying for the composite. And I think that that's going to be the case with the 43, 46.
Yep.
In looking at the 1110 code, I think it needs to be broadened. Maybe there just needs to be a different code for a healthier patient, and maybe the 1110 code needs to be more, maybe like the 43, 46, maybe.
Well, that's kind of what we tried last year.
And they didn't do it?
They didn't. No, it was disruptive. It's interesting with that word, because during the whole time we were at the meeting, that word never came up. It only came up when they sent the rejection, the stuff out. It was interesting.
So
disruptive is interesting. How about factual?
Right. To piggyback on what you guys
that?
are saying, it's against the law to submit a code for a procedure that you did not do. And I think that it would be really smart to bring in a lawyer, to bring in someone who is involved in malpractice. So basically you're asking us to commit fraud. And so for these dentists who get sued because they've misdiagnosed perio, well, they can't create a paper trail for whatever reason, because they're not even allowed to submit based on what a patient has. Either A, because they're afraid to, or B, because no code exists.
Yeah. And then who's to say down the line, ladies, I mean, if they're coming after the dentist for malpractice, then they're going to turn around and say, well, my hygienist didn't do what she was supposed to do. They're going to start
happening.
Absolutely right.
That's already happening. I don't know if you've noticed it, but my malpractice insurance is starting to go up every year. And the only way it does it, hygienists are getting.
Well, the attorneys are looking for any pocket. They don't care.
Yep.
But if the dental office is not submitting the right code, and everybody's a 1110 no matter what. And I mean, I don't know about you, but I don't really have much say with how the insurance gets submitted. That's at the front desk. I treat my patient and I say what I see and I'm done.
Yeah.
Now, what about
Tasha, what are you thinking in terms, I see you sitting there kind of your wheels going.
Yeah. So, I mean, I'm just thinking how we can begin to slowly change or broaden these codes to where we can more appropriately say, okay, this patient goes kind of in this bucket and this is what is appropriate for this bucket. I like the specificity of the 30%, but I'm also thinking, are they going to see that as too wordy, and is localized sufficient? Because when they use the 43, 46, they say generalized. We know how people recognize greater than 30%. So do we need to be that specific? That's kind of where my head is going. But I mean, I agree with what everyone is saying. I'm just trying to think on how we can word it to where it doesn't seem so disruptive in their mind.
Well, you could take the word generalized out of 4346.
I think.
And the other thing too, yeah. And if you go with 1110 is routine, which is 6 months, whatever. Somebody who has, not had a hygiene procedure in over a year, maybe you do that, because that's not right off the bat. That person, more than likely, if they haven't been to a hygienist in a year or 18 months, 2 years, whatever number we might want to give it, they're definitely not by the time that they haven't had our therapy. That's another way that.
Yeah, I hear what you're saying. I think for the codes, like where I'm seeing is that it wouldn't matter if they were out a year or 2 years or 10 years. What is their diagnosis? And if their diagnosis is generalized plaque-induced gingivitis, then in my mind, we should use the 4346. I'm saying whether it's a year or two since the last visit.
I don't disagree, but what I'm trying to say is if they say routine and they're cool with that in their code, then why wouldn't they want us to be able to say this or that? It's only part of it. You're right as far as what they present with, but that also gives us an out. Look at, you're not a routine person. You haven't been in a year. You haven't been in 2 years. You're this code without ever have to checking any other box.
I think that's a slippery slope there.
Yeah. Well, since the word routine isn't in the current language,
Right.
I think we're
It's not in 110 anymore?
No, that was the old,
okay.
Yeah. But you bring up a really good point, that I think dentists in general think it's a routine cleaning.
Right. Every 6 months, right? Every 6 months, right? Well, no, not for you. You have issues.
Yeah.
Mm-hmm. So I don't know if that helps it. You've been out. You haven't seen anybody in 2 years.
Yeah. So my thought is, Carolyn, you look like you've been kind of wanting to say something.
One of the things that drives me crazy about these two codes is one says child and one says adult. And in dealing with kids all day, the patients don't know this, but when you're billing it out, it's pretty much based on age as to how the insurance company is going to pay for it. So it does say primary and transitional dentition, but some insurance companies pay for an adult prophy at 12 years, some pay at 14. The pretty average is 14.
And the thing is, I hear you, but at the same time, we've got to, the ADA actually has a House of Delegates thing from 1992 that said if there's no, that the insurance carriers can't use age, but they do anyway. But when I'm talking to groups, I'm going, I've worked with the dental van with kids for like 10 years, and can't tell you the number of 10-year-olds I have with full dentition.
Yeah, I see that all the time.
And I've got to call them an 1110.
Calculus.
And, it's a matter of talking to the parents. And I actually had on a piece of paper the definitions of both of these. Say, see, your child fits here. I don't know how your insurance carrier may benefit it, but you need to understand I cannot submit any other code. This is what I have to, committing fraud. And I think that was the reason when the AAPD wanted to make one Prophy definition was to eliminate that. But the insurance carriers, actually, someone had submitted last year to put the ages back in. And luckily that was defeated along with ours. But the insurance carriers really like this. And, we could try doing ages, but
I guess I just don't like the word child and adult.
Yeah.
Yeah.
Well, but
just
doesn't it go with if they have a
based
full
on
adult?
primary and transitional, and then prophylaxis based on permanent.
Yeah, but if they have a full permanent dentition, no matter what age they are?
Yeah.
Because
like she said, I've had 10, 11-year-olds with full.
Oh, yeah.
Right.
So,
and calculus and gingivitis and.
Right.
Yeah.
I understand all the verbiage that's needed in the definition. I get that.
Okay.
But, if you're looking at, you're looking up a code for extraction, there's extraction, and then there's a definition of what type of extraction is.
Right.
So I don't understand why they have to say prophylaxis child and prophylaxis adult.
That's we could change that.
And just base it on the definition of primary and transitional, and then all permanent dentition.
Yeah, I would probably make it primary or transitional, permanent or transitional.
But if you put permanent and transitional, then how do you pick which one you're going to use?
Well, I personally, it's by the difficult, the what condition the mouth is in. Someone brought up at the CMC when they were talking about this in 2018, what about the adult who has retained primary teeth? I'm going, let's get in a little minutia, but
yeah.
I hear exactly what you're saying, Carolyn. What do you think, Tasha?
I think the beauty of the 4346 is that there's no age and it doesn't talk about transitional or anything. So if you have a 12-year-old that has generalized inflammation, you can use that code on them. So I agree with the child and adult, but I think that's what we tried to eliminate last year or somewhat, and it got pushed back. But the 4346 at least will help that for those, teenagers that maybe are a bloody prophy,
Yeah.
So we can at least convert them and put them in the right category.
I would love to see what Carolyn mentioned and submit one Prophy code, just take dentition out of it. But I know they will vote it down because they did in 2018, and they're not to that point where they will separate it.
And I guess that's where if you bring a lawyer, they could argue that point for you, saying,
exactly,
a prophy is a prophy. What difference does it make what age they are or what teeth are in their mouth? It's more about the inflammation that's present.
Yep.
And what other medical conditions. I mean, it's no different than, when you bill out medical codes and you go to the hospital, you have to be very specific. A friend of mine's a pediatrician, and they got to be so specific all the way down to which ear has the ear infection and the type of infection.
Yeah.
So, I mean, we're starting to go down that slope. So I think if we could do that, then I think maybe these codes would be able to adjust to diagnosis codes easier.
Would it be what do you think about, I'm just throwing this out there, have one code for dental, and I want to call it dental prophylaxis because the word prophylaxis in the medical community is totally different.
Right.
Yes.
But have a dental prophylaxis with one definition, the rationale being just like on 4346, there's no age, 4341, there's no age, we could put
there's no age on all the codes.
Or dentitions anywhere.
Right.
Yeah, there's no ages on crowns or
Yeah.
So
The other thing that strikes me too is the dental prophylaxis, the 1110, that's more preventive, where the 4346 is more therapeutic.
Right.
So maybe if that's the delineation and the definition that helps to separate the two.
Yeah.
The only challenge with that, and I agree with you, is the only challenge with that is we say it's preventative, but we also have localized severe gingivitis patient in this bucket, right? So I think that's where it is preventative if they have the absence of disease, but it's also therapeutic in a sense because we still have patients with gingival disease in this bucket because there's still so many that fall under the generalized moderate to severe gingival inflammation.
Yeah.
So I actually like, go ahead.
At the last consumption meeting, a lot of hygiene, this was a big topic of discussion, saying that a prophylaxis, while preventive, is therapeutic. And the consensus, at least my impression of the whole meeting, was that it was intended to be preventive back in 90 to 95 and 96 when we did all this, but now it is because of we've been forced to do therapeutic treatment under it because there was no other code available.
And how do you, if I'm thinking like a lawyer, how do you prove that it's preventative?
Exactly, because there's research out there saying,
that's the argument.
I've got articles.
In a court of law, how are you going to prove preventative? I mean, preventative for me could be once a year. Preventative for someone else could be every month. So there's no what's the word I'm looking for? There's no substance to the word preventative versus when we're saying 30% or putting a number on things, like it's like probing depths, you know, we know health based on numbers, and preventative doesn't give us a number, doesn't produce any data.
Nope. And when they've tried, it hasn't.
So if we were to combine to a single Prophy code, single dental prophylaxis code, and eliminate child and adult, what does this team think about? Because ideally that's the healthy patient, and you know, but we know that there's not very many healthy individuals. But what is our thought about it being healthy to localized gingival inflammation, and then having the 43, 46 being that generalized gingival inflammation patient? What is the thought about that?
Do we have to include localized or generalized in either of the codes?
So are you thinking have the 43, 46 being just gingival inflammation, period? Yeah.
Yeah. And I only say that because like they say, it's very disruptive. In a perfect world, I think we should be able to grade it, you know, 30%, 50%, so forth and so on. But now you're having someone chairside trying to decide, and then that becomes, well, what do you consider 30%? And what do you consider localized? And then what do you consider generalized? So it just takes the guesswork out of it. It just makes it easier, in my opinion.
So
see
if I
go ahead.
So take the word generalized out of the 43, 46, and not
have disease or you don't.
Yeah.
Well,
people keep calling it a gingivitis code. Let's make it a true gingivitis code.
You don't just have a little bit disease. Either you have the disease or you don't.
You're never a little bit pregnant.
Right. Exactly.
I think any of us could be the lawyer to say that.
There you go. Does it make sense though then for this 43, 46 to be gingivitis or periodontitis, or does that definitely go into then next scaling?
No, because I think that based on the new research, you can still have periodontitis and not necessarily complaining. So it could be gingivitis or periodontitis.
Yeah. Okay.
And then your diagnosis code would support the code.
Right.
We use diagnosis codes.
Can you hear me? It's Teresa.
Yes.
Oh, hey, Teresa.
So part of the reason I wanted to, like when I had my notes on it, why I would want to eliminate localized and generalized is because if we have numbers, it's just like someone was saying earlier about preventative, it is not quantifiable. So if we can quantify it, then, you know, that's more, I don't know, I think that's more agreeable for this day and age. But the other thing too is, as far as those people that are not periodontal patients, you know, kind of going back to that, they're not periodontal patients, never have been, but they have bone loss due to other reasons and gum loss due to other reasons. I think that, I forgot what my train of thought was there, but I'm feeling like we're going to have so much pushback from a 1110 code for all age groups. And I think that if there's an explanation of primary or transitional dentition other than people who have retained a primary tooth, then that needs to go in the explanation, because obviously it's not transitional because they are past the transitional phase. They have just not exfoliated something.
Right.
And so, you know, in that sense, it would be easier to say primary and or transitional teeth, because then, yes, we will have an age group there, you know. And I feel like the insurance companies will buy that, for one thing. And then, you know, as far as the gingivitis, well, there is a little bit pregnant and a little bit not pregnant, and so forth, because you do have patients that are normally very good. I've had 3 today, normally very good, but then things happen in their life, and then suddenly they're coming with some early or incipient gingivitis. They're not full on, oh my God, there's blood everywhere, which is the way I consider the 43-46, because that's sort of the definition behind that, is moderate to severe. And so I still think that we need to go with these quantifiable numbers of, up to 30%. Obviously, like I said before, we're not going to have a 1110 patient. I mean, unless they're, 18 years old and excellent flossers, we just not going to have it. So again, everybody will be a 43-46, and maybe that's just the way it should be, because then that'll also give better numbers overall across the states as to, hey, this is how many people actually have gingivitis, and this is the degree to which they have this gingivitis. So it's not 50% of Americans, it's 75% of Americans from this age group to that age group, so that it makes more sense quantifiably, and then we can start jumping back on the insurance companies and saying, look, we have this data. We've been, sending this data to you, and now you need to understand that, there's obviously different ways to classify these things. It is not black or white in the sense of they have disease and they don't have disease, and then I would say, like, for instance, I had a gingivitis patient today who I would not actually classify as a 43-46. For her, it was moderate gingivitis. She's a young person, but it wasn't, completely blown out like I would consider a 43-46, a true 43-46. And it definitely wasn't a 1110, but she had tartar under every tooth, but again, it was not like, oh my God, there's heavy tartar here, that kind of thing. So if it's localized, that's not a localized gingivitis to me. It's just gingivitis due to some tartar and whatnot and plaque. So, but does that make sense?
Yeah, it definitely, to me, it definitely makes sense. But I think based on the feedback that I'm hearing and given what got kicked back, I think that would be round 2.
Exactly.
I think that would be round 2. I think we've got to get something going, and then that would be the next step. Coming from an educational standpoint, when you start to get into light, moderate, and severe, that means that everyone has to be calibrated. And I can even tell you, in an institution, when there are 5 instructors, it's even hard for 5 people to calibrate.
Well, and that's where we have to be accountable. We have to say, okay, and we are all told this in school. We know what early, moderate, and severe is. It's just, okay,
but
we're not allowed to use that. And you can write it in your notes, but you can't bill it out and code it, but other than the 43-46.
We're taught that, but even though we're taught that, your definition of early and moderate and severe, believe it or not, it's still variances there.
Yes.
And so that's all I'm saying. We bring in a whole nother element where I feel like we're complicating things. And it shouldn't be that way, but unfortunately it is. So again, I say we do a step 1, and then once we get that passed, we start going into light.
And that's it. I think leaving, like you mentioned, the child and the adult, although we might want to think of it primary. For this step, the word child and adult there, although I agree with Carolyn. But, and then take the word generalized out of 43-46, both in the nomenclature and the definition, and run with those for now. And as Joy mentioned, in 2021, we'll see how things go this time and come back with a little more finite kind of codes.
When
I agree.
the child and adult, you could take that primary and or transitional and replace the child with that verbiage.
Yes, we could.
And then in the adult, just say all permanent dentition.
Yep.
So I have a quick question. The justification for a child prophylaxis, is it because it's cheaper? Is that?
That's what the insurance carriers imply.
Right.
So here's the problem, because I've worked in schools,
I can't hear you.
program where I travel to different schools. I'm spending more time with children than I am on adults.
I know.
And that's why I think it should just be one code, whether it's a child or an adult.
But I can tell you it will not fly
Yeah.
I understand.
at this point in
Because
time.
a 3-year-old versus a 10-year-old.
Makes sense. That makes sense.
So maybe, you know, leaving transitional in the adult, because I know I've had, 12-year-olds with full dentitions and sewer mouths, and I bill them as an adult prophy, because even though it's transitional, I can do that. The insurance care, that's a whole nother ball game, but I like what you said, Joy. I like that.
I guess
So I had to ask just for clarity. Can I ask for clarity? So on the 4346, because I 100% agree with what Joy was saying, scaling in the presence of gingival inflammation, period? Yes? Okay.
That's
Did we mention bleeding?
Joy.
Did we mention bleeding?
I don't think we should. I personally don't think we should go there, but there's a word generalized in the descriptor also before moderate to severe we would want to take out.
But we would take out generalized and moderate to severe and just let it be gingival inflammation, period. Which means they can continue to argue for the 1110 and all of that, but that's basically going to be everyone in the absence of periodontitis.
Well, if there's
right?
30% or more, I mean, I've had adults that, you know, there's just a few teeth that have inflammation, so they would be an adult prophy.
And it just goes to support the science according to the CDCA and the World Health Organization and NIH. 75 to 80% of people experience some form of periodontal disease. So, but the codes that are submitted to the insurance companies don't reflect that. Right. So we go back to everyone's committing insurance fraud.
Right. Joy, if you have access to all those resources to give me a bibliography that we could put in that rationale, so none of us have to look it up. If you could start gathering those, that would be great.
Absolutely. That's my lecture next week, so I'll just send it to you.
Good. Good.
Perfect timing.
So, Kathy, I have a question because now I'm sorry, I'm a little confused because you said if they have less than 30%, they would still qualify for adult prophy. Did you say that?
As a definition. Gingival health.
As by the definition today. Right? I'm sorry, it got loud.
Okay, I'm confused too. The three that we're looking at, the prophy is gingival health or less than 30% exhibiting gingival inflammation. So that stays. And then 4346 is when there's 30% or more of dentition. So gingival inflammation. Okay.
So I think where I'm confused now is that Joy mentioned just taking out generalized, moderate to severe, and just let it be scaling in the presence of gingival inflammation, period.
Correct. Right?
So that would truly be a gingivitis bucket. Like she said, you either have it or you don't. So then my thought is, I don't know if you guys understood that. Is that what I understood?
I hear okay. Because it makes it sound like that would cover everybody with gingival, and I don't think that's. Is that what you're saying, Joy?
Yeah. Yep.
And then truly having the 1110 be for health, right?
Yep.
Which means no one would qualify for that.
A very small segment of the population, which
very small,
according to
which is exactly what. Yes.
That's what the statistics are supporting.
Okay, I hear what you're saying.
Yep.
But truth is,
well, does that include people who have periodontitis but not active?
Again,
well, we'd have to take out the whole blue section because people with reduced periodontium that are healthy would be an adult prophy because it's just gingival health. It says nothing about any kind of clinical attachment loss.
Can
can I just ask then where perio maintenance would come in on any of this? Or does it,
So
does it even get involved?
No,
I don't think it really does, because your perio maintenance.
No, I don't want to touch it. I don't want to touch it. But if somebody's going to code it, if they had scaling and root planing, then they'd go to periodontal maintenance.
Until
this,
they're
this 4346 would be that they didn't have scaling and root planing, but they have the inflammation.
Yes.
That's what we're saying. Okay. Yes. Okay. Want to be on the same page.
Yep.
Thank you, Tasha, for bringing that out, because I wasn't seeing that. Thank you.
Yeah, I mean, I actually think it's beautiful because they're so worried about keeping the Prophy code. They can keep the Prophy code. It doesn't even matter. If we could just change the gingivitis code to say remove it and just be gingival inflammation, then no one would even qualify for those other two codes except for that little minutia, right? So then we can kind of, you know,
basically
have them in the right bucket.
We're leaving 1110 and 1120 alone. We won't even be touching them.
If they choose to downgrade it to a 1110, that's fine, but you know what you submitted as.
Yes, that's them remapping it. They can do that, but we're going to submit what we did. Yep.
Okay, we can do that.
Well, you're definitely going to have to make it clear to on the 4346 as to bone loss, gum loss, not necessarily due to periodontal disease, like bruxism or brushing too hard or whatever. Because the way I'm understanding it now is that those people do not qualify for a 4346.
Unless they have inflammation.
If inflammation is...
Well, if I'm remembering the code properly, it says
absence of periodontitis.
In the absence of periodontal disease.
Right. And
so periodontal disease is bone loss, gum loss. It doesn't have anything to do with necessarily bugs or anything else. It has to do with loss of bone, loss of gum, period.
It's in the absence of, we could put active periodontitis. I don't know. I see what you're saying.
I think that the new...
That's that other code. Yeah, that's that other coding that we were kind of talking about before, is those folks who, you know, have I have bruxism, I have bone loss, I have gum loss, but I don't have periodontitis. Active periodontitis, you know. And so I think that's where that 4346 has to come back into, you know, we have to address those people like me.
So I think that when it says, I'm sorry if I can just interject. I say when it says absence of periodontitis, I think that would cover someone like yourself that has a reduced periodontium with inflammation, right? So you don't have a history of perio treatment. You don't have periodontitis. You don't have deep pockets and accompanied bleeding maybe, but you have some recession, some bone loss from whatever it is, ortho treatment, bruxism. But because it says in the absence of periodontitis, I think that would cover you. So if you do have a reduced periodontium with inflammation, I think you would be fine under that code. That's how I look at absence of periodontitis, because I think the AAP, when they updated in June 2018, they came out with this terminology of reduced periodontium with inflammation or without inflammation. So what I was taught in hygiene school is the second you had bone loss and recession, you had periodontitis. But now I think the guidelines are saying, no, you have a reduced periodontium. You maybe have stable pockets. So I think that phrase absence of periodontitis would cover what we're trying to do here.
I do too.
But that's my understanding of it.
Yep, I agree. So it sounds like a consensus. We're going to submit the 4346 as the gingival inflammation code.
I got thumbs up down there. I saw them too. Yeah. I think that honestly that is easy, and they can't use the reasoning that it's disruptive because it's a brand new code.
No,
based on new science.
It's just amending a current code, which was their language.
Yes, and now
that we are being lawyers. See, we're giving it back using their language.
So all the research we can get to support this kind of, you know,
Absolutely. The Healthy People
photographs, we can put photos into the change request form. Clinical scenarios is a section, so we need to, you know, be aware to do that, gather those kinds of things.
So in the meantime, and I'll get all of that together and respond to everyone, but the Healthy People 2020 objectives, they're coming out with the Healthy People 2030 objectives, and then they have a new oral surgeons report. All of the science is
I love it.
all there.
I love it.
So ladies, are we so bold in the 43, 46 to make some kind of mention in the bottom to also to help assist in controlling oral systemic inflammation? Yes, I just at the last thing, because they have the general inflammation, and again, to Joy's point, where you're kind of going into 1 and 2. If we were to just kind of sneak in the end there, that we're doing this in addition to helping to reduce the inflammation for oral systemic, because then somebody who's coming in as a diabetic patient, and we're going to see them again, we can give them 43, 46. They're not a 1110. Well, so anybody who's oral systemic or anybody who's gingivitis, you know, anybody who's Alzheimer's that has inflammation, anybody who's arthritic who has inflammation, diabetic who has inflammation, you know, somebody who has a history of stroke.
Yep. Well, we could certainly do that, because if you look at the end of the prophylaxis, they put what it's intended to do.
Yep.
There you go.
Absolutely.
So write it up.
So
Eileen, can you write it up and send it to Tasha?
Yeah, I'm jumping out of my seat right now. So it's good.
Yeah. So do you, Eileen, do you want to send me that last statement, and then I can reword what we have here, and then we can, once I get your statement, I'll send it out to everyone to see what people's thoughts are about it.
That sounds fine.
Because we'll need to, this Sunday at this DCC, we have to present. This is what we're doing. We don't have to have all the rationale. We just need the.
I'll have this in the morning. You'll have it in the morning, Tasha.
Okay. Okay. And then I'll send it out as soon as we revise it.
Yeah. Yeah.
Good feedback, guys.
Perfect. Yeah.
You know, Kathy, we should,
a lot.
I hate to say this, but it's 7 o'clock and I've only geared my Zoom meeting for 60 minutes.
Yep.
So
okay.
I want to be respectful of people's time. You can look at the PowerPoint in the Dropbox, which you should all have access to, and see some of the things we need to consider to build coalitions. But someone find an attorney.
Hey, Kathy, I was just thinking to myself that we should ask Maureen West here in Colorado, who is an attorney and a dental hygienist, to be on this task force.
Sure.
There you go.
Let me ask her.
Perfect.
Okay.
I don't have her number, so I was looking for it.
I do.
Okay, good.
I'll give her a call.
We should be able to have something out no later than maybe Thursday morning. So if everyone can just review it and give their thumbs up or a suggestion if something doesn't look right, then we can have something to roll out on Sunday.
Perfect.
Okay. Awesome.
Thank you, ladies.
Thank you.
Thank you, guys. Awesome.
Thank you. Good night, everybody.
Awesome.
Bye.
Bye-bye.
Bye.
Bye.
I want to get out of this. Stop share.